Hello students, this is Dr. Aarthee, Assistant Professor from Vinayaka Mission Sankaracharya Dental College. Now we are going to see about mandibular condylar fracture. Let's see. First, introduction. What is mandibular condylar fracture? It is the fracture line that is above the mandibular foramen that runs from the posterior border of the ramus to sigmoid notch or condylar head that results from direct or indirect trauma. The major etiology of the mandibular condylar fracture is personal violence or due to fall. Then on coming to incidence, 29.3% of all the mandibular fracture comprises of condylar fracture according to Ellis et al. Then according to Zacharias et al., 72% of condylar fracture is associated with other mandibular fractures. And according to McLennan et al., condylar base fracture constitutes of 57% and condylar neck fracture constitutes of 31% and head fracture constitutes of 12% and male to female ratio is 3:1 and unilateral condylar fracture occurrence is higher in incidence than bilateral condylar fracture. Then on coming to biomechanism of injury, Lindahl et al. Gave some beautiful classifications. First is kinetic energy of moving object will be transferred to the static object. So this will leads to fracture in the body of the mandible and unilateral condylar fracture. Second scenario is kinetic energy of the moving object that is to be imported on the kinetic energy on the static object, that is ground. It is called parade ground fracture that will leads to some physis fracture along with bilateral condylar fractures. After that, kinetic energy from moving object and kinetic energy of another moving object. So that will lead to severe impact. So that will lead to bilateral parasymphysis fracture along with bilateral condylar fractures. So next is classification. So how to classify the condylar fracture? So first thing is we have to learn the basics. Then we will go through different types of classification. So first thing is there is no displacement. If fracture was there but it maintains the anatomical position. So this is termed to be no displacement. Next is deviation. When the fracture is said to be deviated, when the fragments of the fracture are in primary contact. Second thing is displacement. When there is no contact between the fracture fragment, it is said to be displaced. And fourth thing, this is very rare scenario when there is extra articulation of the joints happens. Then the mandibular condylar fracture is said to be dislocated. First thing is this is no displacement and the fracture is following anatomical position. Second thing is there is deviation but there is contact. Primary contact will be there in between the fracture fragments. Third scenario is displacement and here there is no contact between the fracture fragments. And one thing I have to explain here is there is proximal and distal fracture fragments. There is fracture line. So this fracture line is dividing the fragments into two parts. So this portion is said to be proximal segment of the fracture. So this portion is said to be distal portion of the fracture, distal fragment of the fracture. Fourth thing is dislocated condyle. So it is, see here the condyle is dislocated somewhere else. So this is very rare case scenario. So on coming to classification, we are having different classification given by different authors. So first is Wasmund. In 1927 he gave classification. He classified the condylar fracture as dicapsular, neck fracture and condylar base fracture. Second thing, McLennan. According to McLennan, he gave one classification of condylar fracture in 1952 as class 1, class 2, class 3 and class 4. Class 1 is no deviation. So the fracture will maintain its anatomical position, and class 2 there is deviation at the fracture level, that is bending of the condyle, but there will be primary attachment will be there between the fractured fragments, and class 3 is displacement of the condyle. In that displaced condylar head remains within the fossa but there is no contact between the fracture fragments, and in class 4 dislocation of the condyle. So condylar head will be outside the fossa, that is outside the glenoid fossa. So on coming to Speisel and Scroll classification, he classified the condylar fracture into 6 types. So type 1 is condylar neck fracture with no associated deviation or displacement. So fracture that follows the anatomical position of the condyle. In type 2, low condylar neck fracture with deviation or displacement, that is said to be type 2. Type 3, there will be high condylar neck fracture with deviation or displacement. So on that to be further classified as type 3A, type 3B, type 3C and type 3D. In type 3A, this is ventral displacement of the condyle, and type 3B, that is medial displacement, the displacement of the proximal segment that to be towards the medial midline, okay, that is said to be high condylar neck fracture with medial displacement or deviation. And type 3, in type 3C, the condylar proximal fracture fragment is displaced laterally. In type 3D, the condylar fracture fragment is displaced dorsally. So in type 4, low condylar neck fracture with dislocation. Then type 5 is high condylar neck fracture with dislocation. This is very rare. And type 6 is intracapsular fracture of the condylar head. Second thing, this is a pictorial representation of Speisel and Scroll classification. So on coming to type 1, see here condylar neck fracture without any displacement. So here there is no displacement or deviation and fracture follows the anatomical position of the condyle. So there is no change in the anatomical plane of the condyle. See, this is type 1. And type 2, there will be low condylar fracture with deviation or displacement. And see, this is low condylar fracture with deviation along with displacement. And type 3, we classified this as further type 3A, type 3B and type 3C and all. So see, this is like medial displacement and this is lateral displacement of the condyle. We can appreciate the displacement. And type 4, on coming to type 4, this is low condylar neck fracture with dislocation is said to be type 4. And in type 5, we can appreciate the dislocation of the condyle. This is very rare. So on coming to Lautoketak classification, he classified the mandibular condylar fracture as type A, type B and type C. So type A, there will be continuous bony contact within the glenoid fossa and with a component of remaining condylar head and the fracture will be supported with no loss of ramus height. So there will be no loss of height in the ramus of the mandible. And in type B, there will be loss of support within the articulating fossa and with the loss of mandibular ramal height. So in type B, there will be no ramus height reduction, and in type B, there will be ramus height loss will be there. And in type C, the highest portion of the fracture is below the level of lateral ligament. As a result, there is a loss of ramus height will be there. So in type C, there is highest portion of the fracture that to be below the lateral ligament. As a result, there is loss of ramus height. So this is ramus height. So ramus height will be lost. On coming to Linda's classification, this is more comprehensive and complicated also, and this is the most frequent classification we are using. So he classified first thing according to fracture head. He is classifying condylar head, condylar neck or subcondylar or condylar base fracture. Okay, so second thing is according to deviation or displacement. He further classified as bending, that is deviation, displacement with medial overlapping of the segments. So the proximal segment will be overlapping towards the midline. So that is said to be type A. And in B, bending or deviation with lateral overlapping segments. And in type C, bending or displacement without overlapping. And in type D, non-displaced fracture without any deviation. So that it follows anatomical outline of the mandibular condyle. So relations between condylar head and fossa, he classified again according to relation between condylar head and fossa. So according to that, he classified no dislocation, slight dislocation of the condylar proximal fracture fragment and moderate dislocation and severe or complete dislocation of mandibular condyle. Then he again classified the condylar head fracture as horizontal, vertical or compressed or comminuted fracture. Here the fracture fragment will be burst out into fragments, multiple fragments. So it is said to be compressed fracture, that is to be comminuted. So according to Lindahl's classification, so first thing is he defined fracture level as condylar head, condylar neck and subcondylar or condylar base. How he classified the fracture as condylar head, condylar neck and subcondylar? Let's we see. So when the fracture line starts at the sigmoid notch and extends to the posterior border of the mandible. See, where is sigmoid notch? It is the U-shaped concavity that is to be present between the mandibular condyle and coronoid process of the mandible. So that is sigmoid notch, right? The fracture line starts from the sigmoid notch extending towards the posterior border of the mandible. So that is said to be subcondylar fracture. Then what is condylar neck fracture? It is located at the condylar process which is below the level of the condylar head. That is said to be condylar neck. Then what is condylar head or dicapsular fracture? The majority of the fracture components or the whole fracture is contained within the TMJ capsule. So that is said to be condylar head fracture. Okay, so next, on moving to dicapsular fracture classification, that is condylar head classification, head fracture classification by he et al. So here he classified the mandibular head fracture as type A, type B and type C. So first thing is type A. See here. Okay, so lateral third portion of the this is medial third, this is central third and this is lateral third. Okay, understood? And second thing is type A. In type A, lateral third portion of the condylar head has a fracture line and there is reduction of the ramus height will be there in lateral third portion. If fracture line is existing in the lateral third portion of the mandible, okay, mandibular condyle. And then type C is central third portion. So this is type B. Okay, of the condylar head has a fracture line and there is no reduction in the mandibular ramus height. Okay, so in type C, medial third portion of the condylar head fracture has a fracture line and there is no reduction in the ramus height. So this is type A, type B and type C. This is according to he et al. Okay, then again AO foundation classification. Okay, this is given by Ellis. In this he draw three lines. Okay, the first line is that runs parallel to the posterior border of the mandible. So this is that line. Okay, so that is this line runs parallel to the posterior border of the mandible. Understood? And second thing is line 2, that is sigmoid notch line. So this is sigmoid notch. So that is between the condylar process and coronoid process of the mandible. So this is sigmoid notch. So line perpendicular to the line 1, but it is in the deepest portion of the sigmoid notch. So that is said to be line 2. And line 3 is perpendicular to the first line and it is below the lateral pole of the condylar head. So this is type line 3. This is also perpendicular to the line 1 and it is near the below the lateral pole of the condylar head. Okay, so the line is also drawn halfway between the line 2 and line 3, which differentiate between high and low neck fracture. So another line you have to draw between the line 3 and line 2. Okay, so this line will be going to differentiate high condylar head fracture and low condylar head fractures. So the fracture line existing above the middle line, which is drawn between the line 2 and line 3, is said to be high condylar fracture, and when the fracture line is said to be below the line we draw between the line 3 and line 2 is said to be low condylar neck fractures. Okay, so on coming to signs and symptoms of mandibular condylar fracture, let's see. So first is pain and swelling over the preauricular region. So that thing, so the area in front of the external auditory meatus is said to be preauricular region. So when there is pain and swelling in the preauricular region, if we can suspect mandibular condylar fracture. Then ecchymosis over the mastoid region. So this sign is called battle sign. So we have to check all these signs and symptoms if patient is reported to you with RTA. Okay. So ecchymosis over the mastoid region. Second thing is cerebrospinal fluid leakage. So that is otorrhea, CSF otorrhea. So that thing also we have to notice in RTA patient. So if patient is having CSF otorrhea, then definitely the proximal fracture segment, that is like mandibular condylar fracture, proximal segment will be pushed into the middle cranial fossa. The fossa connection will be there. So we can suspect CSF otorrhea. Hollowness over the condylar region. When there is medial displacement of the proximal fracture fragment in mandibular condylar fracture, then we can expect hollowness over the condylar region, and restricted mouth opening will be there. Okay, the second thing is trismus, that is locked mandible. So these are, we are having unilateral and bilateral condylar fracture. Okay, how we can differentiate unilateral and bilateral condylar fracture on examination itself? Let's see. So first is unilateral condylar fracture. In unilateral condylar fracture, we have premature occlusion on the same side of the fracture. So there will be fracture on one side of the condyle. So on that fracture side, we can expect premature occlusion. So second thing, open bite, that is due to loss of vertical height on the contralateral side. And next is affected side deviates on opening. So when opening, when you have to ask the patient to open his or her mouth, the affected side means the side which is having the fracture line. So the affected side deviates on opening. Okay, so this is common because of the interruption of the action of lateral pterygoid muscle. So fourth thing is limited lateral movements away from the fracture site, but may be maintained towards the fracture. So lateral movements is like that. Okay, protrusive movements is like that. Okay, so on coming to bilateral condylar fracture, what we can expect in patients with bilateral condylar fracture? Okay, so we can expect bilateral loss of vertical height results in anterior open bite. So if there is bilateral condylar fracture, there will be reduction in the ramus height on both the sides. So the patient will have anterior open bite, and that will lead to posterior gagging of the mandible. Okay, these things and all you have to watch while examining the patient itself. Then patient is also having restricted mouth opening, and it may be associated with other fractures also. If patient is having bilateral condylar fracture, so patient, we can suspect symphysis fracture also, and in patient with bilateral condylar fracture, we can expect bilateral parasymphysis fracture also. So likewise, we have to think and examine the patient. Okay. Next is investigation. So what are the investigation we have to do to detect mandibular condylar fracture? So first thing, in our dental setup, we will prescribe for OPG. Okay, so that is orthopantomograph. Orthopantomograph will helps to identify anterior-posterior displacement of the condyle. Then after that, Torres weave and AP mandible coronal weave, that and all will help medial and lateral displacement of the fracture fragment, mandibular condylar fracture fragment. Okay, then after that, coming to CT, that is computer tomography, that is a gold standard investigation method for identifying mandibular condylar fracture. So we can appreciate three-dimensional displacement or deviation of mandibular condylar fracture. So we have to go for CT scan. Okay, so whenever we are suspecting condylar fracture, so that is said to be gold standard. If we are suspecting any injuries in the muscle over the TMJ, or we are suspecting internal dearrangement of the TMJ, so we can ask the patient to take MRI. So that is, what is MRI? Magnetic resonance imaging. So that is MRI. So we can ask for MRI in those patients. Okay. Then after coming to the treatment, so first thing is we classified the fracture and we know how to identify condylar fracture, what are the clinical features of a condylar fracture. Next thing, how to investigate the fracture, and after that we have to see about treatment. So that is the most interesting part and most needed part also. So first thing is, what are the factors we have to take into consideration for treatment, to proceed to treatment. Okay, so first thing is location of the fracture. So to identify location of the fracture only, we studied lots and lots of classification. Okay, after that, one more important thing is amount of vertical reduction in the height of the mandible. So that thing you have to notice before proceeding to the treatment plan. Okay, so third thing, degree of angulation of the condyle. and degree of luxation of the condylar head out of the glenoid fossa. So that angulation also you have to measure. Fragmentation pattern, whether it is simple fracture, compound fracture or comminuted fracture, that thing also we have to notice, we have to examine. And association with other mandibular fracture. Dental occlusion and status of dentition. So what is occlusion? Which side is having premature occlusion, whether the patient is having open bite, everything you have to consider while planning the treatment plan. Okay, so association with other facial bone injuries, other mandibular bone injuries also you have to notice, whether a patient is having other facial bone injuries, that thing also you have to notice. So after that, like condition of the patient at the time of examination. So if patient is undergone RTA, so you have to examine thoroughly. So other comorbidity factors also you have to consider while planning the treatment for this patient. Okay, then after that, foreign body in TMJ. When foreign body will enter into TMJ, when there is gunshot or when there is accidental fall, some glass pieces will go into the condylar fossa. So that thing and all you have to examine priorly. So that thing and all will predict the treatment plan. Okay, so next thing is management, how we are going to manage the condylar fracture patient. Okay, so first thing is investigate. We investigated the patient and we found the patient is having condylar fracture. Then how to proceed the treatment? We are having like non-operative treatment plan and operative treatment plan. How to differentiate which patient needs operative treatment and which patient needs non-operative treatment, that thing and all we are going to see. Okay, so what is non-operative treatment means? We have to observe, we have to closely observe the fracture fragment, whether they are uniting, whether they are maluniting, that thing and all you have to observe. So we have to follow up the patient regularly. In the patient, those who are coming in the category of non-operative treatment. Okay, then after that we have to prescribe physiotherapy. These are the treatments under non-operative procedures. So in operative, we are having closed treatment and open treatment. Okay, so in closed treatment we are having MMF, that is Maxillomandibular Fixation. So we are going to fix mandible along with maxilla with some wiring. Okay, so you all know arch bars, screws or with elastics or wire. So we are going to fix the maxilla along with mandible. So that is called Maxillomandibular Fixation. That is for immobilization of the jaw. Okay, so second thing is, then on coming to closed open treatment, so we are having open reduction. So we are going to open and see the fracture fragment, fracture line, and after that we are going to manually reduce the condylar fracture, and after that you are going to put any plates or any wires to fix the condylar fracture. So this is said to be opened reduction and internal fixation. So what are the approaches we can follow to open the condyle? Okay, so that is the approach to be determined by surgeons. So the first thing is surgeon's preference, and second thing is fracture location, and third thing is type of fixation we are going to do. Okay, so that thing and all will come later, we will discuss later on. So first thing is on coming to non-operative treatment. So main indication when we can go for non-operative treatment. So non or minimally displaced fractures in compliant patient. Okay, so when there is like fracture line without any changes in the anatomical outline of the condyle, we can go for non-operative treatment. So what are the requirements? Dentate patient should have a stable occlusion. So first thing is you have to check for occlusion. When the patient is have stable occlusion, we can go for non-operative treatment. An acceptable level of pain. Pain scale we have to notice by visual analog VAS scale, and in that if pain is manageable we can go for non-operative treatment. And patient complaints, according to the patient complaints also we can decide. Okay, we can choose a non-operative treatment. When the patient must be advised that additional treatment may be required if complication arise during the observation period. When patient is undergoing non-operative treatment, on like regular follow-ups we can find like any malocclusion or sudden displacement of the condylar fragment. So on that case we can advise the patient to go for open reduction and internal fixation also, or closed reduction also. So that thing and all you have to explain the patient priorly. So what are the things that comes in non-operative treatment? First thing is rehabilitation, that is exercise, and you have to regularly follow up the case. Okay, so at the interval of 1 week time, and after that you have to prescribe soft diet. After open reduction and internal fixation also we have to prescribe soft diet for the patient. Okay, so next thing is, these are the methods evaluated, okay, for the immobilization of the condyle. Okay, so these are the ancient times. From ancient times we are following different types of things to fix the condyle. So this is wire, this is one hook to reduce the condyle, and after that they will fix by using wires. So these are different authors had given different types of fixation in different years. Okay, so this is Silverman in 1925 gave like this kind of immobilization of the condyle. Thoma in 1945 gave some fixation of the condyle through transosseous wiring. So a simple wiring he used to fix the condyle. Okay, so Robinson and Dune, Kobach and Moma. So treatment plan started to evaluated from 1925 onwards. On coming to closed treatment, we are having maxillomandibular fixation along with some functional treatment will be there. So in closed treatment, what are the adaptation we are going to do in the patients? What are the adaptation we can expect from the patient? So first thing is skeletal adaptations. Okay, so second most thing is neuromuscular adaptation, and third is dental adaptation. So these three adaptation we have to expect from the patient in closed treatment. So first thing is neuromuscular adaptation and skeletal adaptation and dental adaptation. Okay, so first thing, on coming to open treatment, we can expect only neuromuscular adaptation, because we are adapting the fracture fragments with the plates or wires or something. Okay, so in closed treatment we have to expect the treatment to be adapted in three adaptations. First thing is neuromuscular adaptations, skeletal adaptations and dental adaptations. So let we see advantages and disadvantages of the closed treatment. Okay, so we are not going to open and see the condylar fracture. So you are going to do closed treatment for the patient. What are the advantages? First thing is relatively safe procedure and no injuries to the vital structure. If you are going to open condylar fracture, you can that will affect the facial artery, facial nerves and all. So first thing is we have to be very conscious in choosing the approaches while going for open treatment. Okay, so first thing is advantages. So what are the advantages closed treatment of condylar fracture is having? So first thing is, which is relatively safe procedure, and there will be no injuries to vital structures, and hospitalization may not be required for those patients. So on coming to disadvantages, closed treatment will also have certain disadvantages. So what are the disadvantages? It is having long period of intermaxillary fixation. So minimal period for MMF is 3 weeks. So 3 weeks we are going to immobilize the jaw. So that will be very difficult for the patient. So growth disturbances can occur in children. So high chance of TMJ to be unclosed. So this is the most important complication when we are planning to give maxillomandibular fixation in children. So main disadvantage is growth disturbances. So you have to think twice, okay, while planning treatment for condylar fracture in children. Okay, so success depends on patient cooperation. Patient cooperation is must for successful treatment. For each and every treatment, patient cooperation is must, and long-term follow-up needed. Okay, contraindicated in medically compromised patient and challenge in partially or totally edentulous patient. Okay, so second thing is maxillomandibular fixation. As this is a procedure which is going to help in the immobilization of the jaw. So that is going to fix the maxilla with the mandible. So what is a minimum period of MMF? That is to be within 2 to 6 weeks. And MMF can be obtained by using arch bars, IV loops and IMF screws also we can obtain. We can use this much modification in the treatment of MMF. Okay, so MMF may entirely be based on the level of fracture. Thing is, we have to classify the fracture, and after that we have to decide whether this case is suitable for MMF or whether this case is suitable for open treatment. Okay, so first careful examination of the patient will be more important. Lower the fracture, the longer the period of immobilization, but think in case of children. Okay, in case of children, what is the like important complication? We have to think about TMJ ankylosis. So period of immobilization may be changed, okay, for planning treatment in children. Okay, so you have to think twice while planning treatment plan. In children, immobilization may range from 7 to 10 days, okay, as there is high chance of developing TMJ ankylosis. So on coming to functional treatment, what is functional treatment? It relies on guiding elastics and active movements. So we are going to fix arch bars or IV loops or IMF screws, but after that we are going to place elastics. Okay, so that will be able to open jaw, that will be useful to produce active movements in the jaw. So elastics are given to achieve repeatable occlusion. So the patient can be able to open his or her mouth. Okay, so initially heavy elastics are placed and then slowly shifted to light elastics. So during the meals, elastics should be removed. So for cleanliness, okay. So second thing is, after an initial period of 2 to 4 weeks, elastics are replaced only during the night. So first thing is we have to place elastics. We have to ask the patient to always wear elastics even though in the daytime. So after 2 to 3 weeks, we have to encourage the patient to wear elastics only in the night. Okay. So minimum elastics must be used as a aim to permit maximum mobility of the jaw. So main motive of functional treatment is to mobilize the jaw. So you have to place minimum elastics. Okay. So functional treatment can be supported by myofunctional orthodontic treatment also. So we can give myofunctional appliances for children with condylar fracture. So that will help in what we saw 3 adaptation, so that and all helpful in the adaptations. What are the adaptations? Neuromuscular adaptations, skeletal and dental adaptations. Okay, so second thing, what are the aftercare? What are the things you have to follow after following closed treatment? First thing is follow up, and second thing is for pediatric condylar fracture or any patients, you have to inform, we can further modify the treatment plan according to the outcome of the treatment. And especially for pediatric group, we have to inform the patient can affect the future mandibular growth in some rare cases. So that thing and all you have to inform the patient clearly, and you have to get consent. Okay. So the second thing is, it is prudent to recommend, so regular follow up will be needed for each and in adult group or pediatric group. Regular follow up will be needed when the patient is undergoing closed treatment. Okay. So next thing is, these are the things to be taken care after the treatment, closed treatment. First thing is diet. We have to prescribe soft diet to the patient, and second thing is we have to advise the patient to maintain good oral hygiene, and you have to good oral hygiene by what? By mouth rinses, by prescribing mouth rinses or mixture of hydrogen peroxide or water pick instrument, because that will be useful to help remove debris from the wires and all. So third thing is physiotherapy to restore mandibular excursions. Okay, so maximum jaw opening, right and left lateral. So physiotherapy, what is physiotherapy? What are the movements we have to ask the patient to do? Okay, physiotherapy is basically movements. So what are the movements you have to the patients to do? First thing is maximal jaw opening, that is you have to instruct the patient to open on maximum. Okay. Second thing is right and left lateral excursions. So you have to ask the patient to excurse the mandible on right and left side. So that is so like that you have to instruct the patient to move his or her jaw. So third thing is protrusive movements. Okay, so that what is that protrusive movements? This is so like that you have to ask the patient to move the jaw towards front. Okay, that is protrusive movement. On coming to open reduction, so we are going to open. Okay, so we are going to put incision and we are going to see the mandibular condylar fracture, and after that we are going to fix the fracture. So this is called open treatment. Okay, so what are the indication for opening the condyle? So Zaid and Kent had given absolute and relative indications for opening the condyle. So first thing is absolute indication. So what are the absolute indications? Condyle displaced into the middle cranial fossa. So on that time we have to open the condyle absolutely. So second thing is not possible to obtain like occlusal discrepancy. Okay, so third thing is lateral capsular displacement of the condyle. When there is like lateral displacement of the condyle, we have to go for open reduction and internal fixation. So third thing is presence of foreign body. In case of a gunshot injury or like any accidental fall, any glass piece or something went into like condylar compartment, so that on that case we have to definitely open the condyle. Okay, so what are the relative indication for like open reduction? Bilateral condylar fracture in edentulous patient without splint and comminuted midface fracture, prognathic or retrognathic jaws having associated bilateral condylar fractures, generalized periodontal conditions and jaws totally or partially edentulous. Unilateral condylar fracture with lack of base. So these conditions are the relative indications for opening. Okay, so according to Fonseca had given like indications, some absolute and relative indications for open reduction and internal fixation. So what are the absolute indication? Same again, when the condyle displaced into the middle cranial fossa, when there is like a presence of foreign body, and extracapsular displacement of condyle, which is to be laterally, which is in the lateral displacement, and malocclusion not amenable to close reduction. So dental discrepancy which is not to be managed with a closed treatment. So that cases we can pick up for the open treatment. So open reduction and internal fixation, when there is like we are not able to do like dental adaptation in like patients with closed treatment, we can take up the patient for open treatment and internal fixation. Okay, what are the strong evidence for open reduction? Bilateral fractured condyles, condyle displaced grossly, so that is angulation greater than 45%. In the starting itself, we had seen the like factors which indicate which have to be seen to plan the treatment for mandibular condylar fracture. So in that we had seen like fracture, like condylar angle. Okay, so that thing and all you have to see. When the angle is like greater than 45 degree, we have to definitely open the condyle and fix the condyle. So anatomical reduction of ramus height that is greater than or equal to 2 mm. When there is reduction of ramus height which is greater than or equal to 2 mm, we have to definitely go for open treatment. When the condylar fracture with unstable base and unstable occlusion generally seen in periodontal disease or less than 3 teeth per coordinate. So that cases and all we have to do open reduction and internal fixation. Condylar fracture for which adequate physiotherapy is impossible. So when there is like lot of muscular thing and loss of internal arrangement, we have to definitely go for open treatment, because on that patient we are not supposed to advise the patient for physiotherapy. So that patients and all we have to do closed open treatment. Okay, these are the like mixed evidence for open reduction when there is moderate displacement. So in the strong evidence we had seen greater than 45 degree. In the mixed evidence he is given 10 to 45 degree. Remaining thing condylar fracture in children except for absolute indications. So we have to go for open reduction. Okay, so reproducible occlusion without drop back or with drop back that returns to midline on release of the posterior force. Okay, these cases and all we have to go for, we have to plan open fixation. Okay, so what are the advantages? Anatomical reduction of the fractures will be obtained by ORIF procedures and short or no intermaxillary fixation will be needed. So patient will be free, he can like easily open his jaw and he can eat whatever he likes, expect the like chicken bones and all. Okay, he can take soft diets, at least he will be open his her mouth, so that will be like easy for those patient. And early function, he can return, so he can like chew whatever he likes earlier. So that thing is a main advantage for opening like in ORIF. What are the disadvantages we are having? Infections, hospitalization required and complications such as scar and injuries to the neurovascular structure that to be like carefully evaluated during the surgical approaches. So and then steep learning curve for surgeon, and after that cost of treatment also will be high. Okay, so on coming to dicapsular fractures, what approach we are going to see the condylar fracture? So pre-auricular approach or retro-auricular approach will be used to see dicapsular fracture. Okay, so first thing is we are going to open the fracture. Then what approach we have to choose for like condylar neck fracture, condylar head fracture and subcondylar fracture. This is given here. Okay, so neck fracture. In neck fracture we can go for intraoral approach, periangular approach, retromandibular approach, preauricular and postauricular. Let me see one by one, but first we have to see like which at what fracture level we have to go for what approaches. Okay, that thing we have to see first. So for base fractures we can go for intraoral approach, that is transoral approach, periangular approach or retromandibular approaches. So this is submandibular or periangular approach. See, the incision line will be here and we can assess this much of mandible. Okay, so we can able to see, visualize the mandible, this much of area, the green shaded portion we can visualize through periangular or submandibular approach. Okay, so for in retromandibular approach we can visualize this. Okay, so this is the incision, this is retromandibular approach. Okay, in preauricular approach, that is to be placed in like just near to the external auditory meatus, this is preauricular. So we can visualize the condylar neck. So dicapsular fractures and all like neck fractures and all, we can go for preauricular approach. Then on coming to reduction, so first thing is open, we open the condyle by like whatever approach. Okay, that is basically on surgeon preference and according to the fracture level we have to choose the approach. Okay, which approach we are going to see, open the condyle. Okay, so after that we have to reduce the condyle. So which method we are going to reduce the condyle? First thing is manual digital traction. Thumb is placed on the lower teeth and fingers support the lower border. So we have to support the mandible like this, and mandible is pulled on the inferior and anterior direction. So we have to put one screw in the proximal fractures fragment, and if the condyle is like displaced laterally or medially, we can like pull the mandible in inferior and anterior direction by manual digital traction. So like this we can reduce the fracture line. Okay, so second thing is we can use bite block instead of our hand. Okay, so instead of using here, they had used their hand. So this is manual digital traction. So next thing is bite block. They can use bite block here to displace the distal fracture fragment of the mandible. Okay, so on coming to like transosseous wire. So how we can use transosseous wire for reduction? So one transosseous wire can be passed along the posterior inferior border of the mandible here. Okay, so we have to drill one hole and we have to do like transosseous wiring here, and you have to inferiorly pull the mandible for a reduction, proper reduction of the fracture. So like this we can reduce the mandible. Then how we are going to fix the mandible? Okay, so see, these are the different types of fixation we are having. So now we are like fixing the mandible by using mini plates, that is of like titanium material. Okay, so these are the different shapes. We can fix like mandibular fracture with one plate. Okay, that is to be in the central of the long axis of the fracture line, and we can fix by two plates, one 4-hole plate with gap and one 2-hole plates also. And after that we are having delta and lambda plates also. These are like evaluation of fixation. So now these are the emerging methods we are having in the fixation of the condyle. So at the time of surgery fixation, technique is selected based on the following parameters. So according to the fracture morphology, so on choosing like which shape, how many plates, how we have to choose the fixation procedures. So we are having this much thing to fix the mandibular condylar fracture. So how to choose the treatment plan, like fixation tool? So first is fracture morphology can be used to plan the fixation procedure, and second thing is amount of bone available there. Okay, so third thing is surgeon preference. So the emerging like fixation procedure is mini plates. So by mini plates we can achieve like anatomical fracture reduction and fixation. So hereby I am concluding my lecture. Thank you all for like watching my lecture. Thank you so much.